Afternoon, everyone. Thank you very much for coming to this talk. There was no one here 10 minutes ago, so I was worried I was talking to an empty room, so you all came in en masse. Thank you for listening to my talk. We'll see if you're grateful at the end of it. And before I start, thank you also for the conference organisers to allow me to share some of the things we're doing in the NHS and other hospitals in the UK, which have a complementary therapy and lifestyle bias. But actually my day job is a mainstream oncologist. I give chemotherapy, radiotherapy, I inject radioactive seeds into people's prostates every Tuesday, and I give horrible poisons and hormones and biological agents. So that's what I do for a living. So that's what pays the mortgage. But what I'm interested in academically is developing strategies or self-help strategies and complementary strategies which can support people through their cancer therapies. And we've set up a research unit in Bedford linked to Cranfield University and with other organisations across the UK to design trials to prove probably what we already know is true. But nevertheless, I'll share that with you now. So first of all, cancer is a relative success story. You wouldn't say that if you've had cancer and you're not being cured. Nevertheless, if, for example, when I first became a consultant 14 years ago, or 15 years ago, the chance of surviving, say, prostate cancer was about 30%, and now it's on average 70%. Breast cancer, for example, if there was about a 54% chance of surviving breast cancer, and just in my lifetime as a consultant, now it's 84%. So, of course, there's still a long way to go, but things are improving, and that could be because we're detecting it earlier. We probably have better treatments. We maybe better support treatments, but we don't know yet. But the thing is, because the incidence of cancer is going up slightly, and the chance of living with cancer for longer is improving, or in some cases being cured, that means the number of people around at one time who's been through the cancer experience is going up. So there's about 2 million people now living with cancer, but it's forecast to go up to 3 million by the year 2022. And put in perspective, there's about a quarter of the population over 65 have had cancer. So there's a big group of people who've been touched by treatments and are living with the long-term consequences of cancer treatments. When any of you have met someone with cancer or been through cancer treatment yourself, you'll know that there's a big problem with fatigue, cognitive disorders, poor appetite, long-term bowel problems, increased risk of thromboembolism, low quality of life, and even down to, you get poorer when you've had cancer treatment, so you have fiscal toxicities, you have marital strain, social isolation, all these things. Now, up to now, in fact, what I was taught, or not taught, was that once you've finished your chemotherapy, your job is done as an oncologist. But of course, the impact of that disease to that person is going to carry on for the rest of their life. And most oncologists turn their back to them and say, it's not our job. The job is to give chemotherapy and radiotherapy, and off you go. And they're handed back to the GPs, who then say, it's not my job either. So you get this limbo of people living with bowel problems, fatigue, with no one to look after them, or no one to advise them. And fortunately, the tide is turning. Most of the well-established oncology journals throughout the world, now this isn't, the South Wales Gazette, these are sort of major journals, Journal of Clinical Oncology. If you look at them now, there's always one or two papers on trials to show how we can support people through the cancer experience using practical self-help and self-help programs. So it's beginning to change. Now, this was the most important thing in the UK. This is called the National Cancer Survivorship Initiative. This was a really good initiative, probably pushed by Macmillan, the largest cancer charity, with the Department of Health. So it's addressing the symptoms we were just referring to find out how we can help patients. So I led the evidence review with Macmillan on this document. And it was a 5-year project. It was just coming to the end. There was different cells. There was breast cancer, fatigue, all these sort of things. And it came up, if you open that website and go on to the summary introduction, it comes up with these bullet points. Now, these bullet points are now should go into mainstream practice So oncologists now should be looking at these and adapt strategies. Of course, it's not as easy as that, because if we say to our managers we need money to set up a counselling service, they will just stare at you and say we haven't got it. So you can make recommendations. Whether it actually happens is a different story. So, but as you can see, it's saying you need to address the holistic needs of patients and the family at every stage of the cancer journey, which also means afterwards if they have symptoms, which mostly they do. But, you know, it's saying we should signpost a well-being clinic, we should look at lifestyle issues, we should look at dietary issues, psychological issues, and even spiritual issues. So I get 3.5 minutes per patient, so I don't tend to ask them about what religion they are and if their spirit needs are met. But of course, to do these is going to involve a major culture change for the NHS, which, well, we just hope it'll happen. But at least there's the seed of an idea there, isn't there? But it's not just about symptoms. There is evidence, as you all, I'm sure of you know in the room, that you know, a healthy lifestyle and positive interventions can actually change the progress of cancers. We know cancers are in our genes. We're born with cancer in our genes, and we eat a carcinogenic substance, or a Pringle or such like. No one from Pringles, don't shoot me. They have the highest content of acrylamides in the food source, Pringles. So if you go on the FDA website and put acrylamide content, it comes up about 1,000 times higher than anything else in the food chain. And if you Google cancer in a can, Pringles comes up. So anyway, so a little aside there. So if you have a Pringle, you get all these horrible acrylamides, they cleave your DNA, so the genes which have locked cancers in place through evolution or whatever, that get dislodged and the cancer grows. So you could say, well, hang on a minute, you've just said it's come out of place, the cancer's growing, how can lifestyle or good nutrition alter the progress of a cancer? Well, you may know that we get cancers every day, because we don't eat perfectly, do we? And even if we go in the sun, we get cancers. But our immunity does mop them up. Only when it gets overloaded that cancer progresses through to a metastatic situation, which is fatal. This pathway here, from cancer cells to start growing fast, is called de-differentiation, to start changing the organ they came from, creating new blood vessels. They have to, when it gets to a critical size, about 1 centimetre, you have to draw in new blood vessels for it to grow. It's called angiogenesis. It has to lose the stickiness to the site of origin. It's called loss of adhesion. And you have to then metastasize through the bloodstream or the lymphatics and then invade organs, and that's eventually what would kill you. So all these pathways require further genetic breaks, so further exposure to carcinogens and further free radicals, etc. It's related to your immunity, your hormonal balance, and this is the thing which I believe you have some control over, because you've already done that, isn't it? So this is the pathway. You know, most drugs now in oncology are all aimed at targeting one of those mechanisms. But of course, we know that lifestyle does that as well. And this isn't just my idea, and it's not even a new idea. Stephen Paget, 2 centuries ago, one of the forefathers of oncology, said, while many researchers have been studying the seed, which is the cancer cell, properties of the soil may be important. In other words, our bodies. So any gardeners in the room? Yeah, must be. Yeah. I gave this talk in Singapore last week, and I put any gardeners in the room, and they just stared at me, because there's no grass in Singapore at all. Anyway, there is in Britain, and so anyway, we all know you can have the best seeds in the world, can't you? If you've got bad soil, it doesn't grow. And the opposite is for us. We want our soil, our bodies, not to be receptive to cancer cells. And also, I was quite pleased with the 50 years of oncology achievement by this journal, major European journal, said in the last paragraph of a 200-page document, cancer research should concentrate on why some organs or individual give permission for cancer cells to grow. Why is it you have 2 people with identical cancers, identical stage, one it metastasizes, one it doesn't? It could be just the luck of the dice, or it could be they've managed to change their soil, their body, to fight against the cancer. So what are the things within the NHS we can do? Well, obviously exercise is probably number 1. Why? You still get, I was giving a talk in Yorkshire a couple of weeks ago, and there's no evidence for exercise helping, and patients have got, they're fatigued, they're on chemotherapy. It's cruel that you're telling them to exercise. They should rest. They obviously not read this journal. This looked at 33 randomized controlled trials of exercise interventions with people who've been started hormones or chemotherapy or radiotherapy. And there was absolutely no doubt if you make a little bit of an effort and push yourself to do mild daily exercise, you have less fatigue, you get less depressed, your overall quality of life goes up. So I know it's hard to persuade patients this, but it's clearly important. Not just that, I could present about 10 slides of this, but we've only got half an hour, and it'd be nice to have a discussion afterwards as well. These are large cohort studies of people who've had, in this case, breast cancer, and it looked to see who exercised after and who didn't, and it looked at the relapse rate. If you managed to exercise about 3 hours a week, you had, in this case, a 67% lower risk of your breast cancer coming back in this study. And this is JCO. These are major journals. This one is another study looking at breast cancer, 4,500 nurses' health study. There's the same for prostate cancer, same for bowel cancer. They all show the same thing. You get a significant association with a reduced relapse of your cancer if you exercise regularly. And this is the same evidence for prostate cancer. All the references are at the end of this talk, by the way. If you want any references, you can email me and you can get them. We have made some inroads, and you've all heard of NICE, the National Institute of Clinical Excellence. If you start anti-androgens or Zoladex for men with prostate cancer, we now have got written in the NICE guidelines that you have to send patients on a 12-week exercise referral course. We've been doing this in our centre for 5 years already. So you give a prescription for their drug in one hand, and you give a prescription for the gym or a walking group in the other hand. Now it's written in NICE guidelines. We're lucky because we've been doing it for 5 years. The rest of the country are desperate to scramble together and form exercise groups to be able to meet this guideline, because if you don't, you fail peer review and your hospital doesn't get paid. So this is, I'm afraid, it's all very nice showing the evidence and everyone just goes away and ignores it. They can't ignore it now. They have to do it. And it's great. So even I work in Addenbrooks in Bedford. In Addenbrooks now, they've set up about 10 committee meetings over the last 3 months, and it's all happening, which is great. We just need to do that for all cancers now. So what are the other things we look out for? We don't screen for depression very much. This was a nice paper which was published in the Journal of Clinical Oncology from California, and it looked at 42,000 men with prostate cancer, and it found that there was clinical depression in 2,500, so a low percentage, but significant. And the relapse rate in the depressed men was 30% greater than the non-depressed men. And that was led to mortality. So the mortality rate was different. And that was not because they jumped off the Golden Gate Bridge. That was because their prostate cancer relapse. So, depression changes your body to cause cancer to grow or relapse. And, we do supposedly have psychologists attached to oncology units, but I've never seen one. There's a study from Klebowski, which is a randomized controlled trial which got women after breast cancer into an exercise and dietary lifestyle package against standard care. And again, there was I think it was a 14.5% difference in overall mortality if you went into a lifestyle program. And that doesn't seem very much, but that's the benefit we're getting from oncology drugs. We're getting about 10% improvement when we give adjuvant treatment. So it's 1/10 of the price and more effective than the drugs we're giving just to put people into a program. And that's a randomized prospective study. That's not just the other one. Obviously, a lot of the treatment we give makes people postmenopausal and damages their bones. They've got osteoporosis, so you've got increased risk of fractures. But more importantly, there was a large study from ASCO, which is the world's best cancer conference. This was a comparison of 2 big blockbuster aromatase inhibitor drugs, which is a treatment for breast cancer. And it didn't show any difference between the two. But what they also looked at is whether you had osteoporosis or not. If you had osteoporosis, you had about a 14% reduction in survival than if you didn't. So actually, that was just an aside on that trial. And they were saying, it's a bit disappointing, we couldn't see any difference between these 2 drugs. They sort of largely ignored the fact that it was sitting in the face, that if you had osteoporosis, that was a very bad thing to have. It did seem to improve if you had bisphosphonates, but of course, what we now do is give people information sheets when we start these drugs, which can cause osteoporosis, And we can download them before they get osteoporosis. And just practical lifestyle tips, like, for example, getting your protein mainly from pulses and soya rather than meat, not smoking, being physically active, and, generally having a good diet with lots of calcium, vitamin D, and sunbathing sensibly. So, there's practical things which don't cost anything, which might actually improve the outcome. This isn't me, I don't think, from last night, no. This was just to remind me that, this is pretty obvious. If you smoke after cancer, not just head and neck or lung cancer, if it's head and neck and lung cancer, you double the risk of your cancer coming back within 1 year. So, it's pretty obvious, but... So what we're doing now, certainly in our centre, and now developing across the country, is trying to get patients to go down that route and not that route. So we've been working with various organisations, particularly Macmillan, who are very good at driving this lifestyle issue. So this is what we've set up, a lifestyle and holistic needs hub. So at the beginning of treatment, patients are told about their treatment options and side effects, which is still very important. Towards the end of treatment, they're then sent to a lifestyle information officer. If they smoke, they go into a smoking cessation clinic. If they're overweight, they go to a dietitian. If they've got a physical problem, to a physiotherapist. And then they're referred to, they're given lifestyle information. So if they want, they can get a referral to the local gym for 12 weeks. The Macmillan website, Macmillan have taken over the Rambler Society. I don't know if you knew that. So Ramblers are now owned by Macmillan on an aggressive takeover thing. So, but it's quite good. If you put your postcode into the Macmillan website, the relevant page, you can then find out the walking groups in your area, what time they start, and how to get yourself on it. So instead of just saying to a patient, you need to exercise, you actually say, do you like walking? Yes. Well, okay, next Thursday morning, 9:30, outside the town hall, here's your bit of paper. So it's actually pushing them in and guiding them rather than just telling people. And that's working quite well. In the gym, there's level 3 trained exercise professionals. We've developed a qualification for level 4, which means when you send someone to a gym, if the gym instructor's been on this course, they've understood what a cancer patient has gone through. So if they say, look, I've got dry eyes, they can adapt exercise to protect the eyes. They might have hand-foot syndrome. So that's quite good. It gives patients more confident that the person who is telling them to exercise have and some understanding what they've been through. And that's being rolled out through that company across the UK. Now, that's the NHS. I've also, don't throw eggs, I also have something to do with a private company called Cancer Partners UK, which is the second largest provider of radiotherapy in Britain. They've got units, they've got about 8 units in these areas. And I'm sort of their survivorship consultant or whatever. This is actually quite nice. I mean, they're a private organisation. They're really concerned about every penny they spend, but they see complementary therapies as a cost-effective bonus to radiotherapy, which is great. So they've linked up with Penny Brown in Bristol. And what happens now, every unit, we have a Living Well coordinator who does a formal holistic needs assessment, given lifestyle choices, which we give in our NHS centre. But on top of that, they actually give acupuncture, reflexology, and mindfulness. And when we last had a meeting with all the units, there was an 80% uptake in one of those 3 things. So this is good news, that we'll be able to get a few complementary therapies through into mainstream practice. So coming on to nutrition. Of course, within the NHS, if you've got malnutrition or if you're overweight, you will get supported by dietitians. Although we don't have nutritionalists, so talking about healthy or unhealthy food, they don't really get any advice. They think that if you're diabetic, they'll give ways to reduce diabetes, and that's it. But we know that this sort of thing, and probably everyone in this room, because of the fact you're sitting here, probably eat fairly healthily. But we know that foods with lots of polyphenols, so berries, nuts, pulses, all these other things. We know from these large 5 studies, well, more than that, because there's 2 there, that populations who have lots of this sort of diet, or green tea, herbs and spices, have a lower risk of breast cancer, particularly fruit with pancreas, which seems odd. You think fruit's got too much sugar, but it didn't seem to matter in this trial. And the prostate, of course, it was the colourful tomatoes and vegetables. Tomatoes gets lots of press with prostate cancer, including a study last week which raved on about tomatoes. But actually the study showed fruit and veg and tomatoes, it reduced prostate cancer. But obviously the person who wrote the article must have a tomato factory or something, because they only mentioned the tomatoes. But it's all colourful fruit. So we know that you can reduce your risk, and the World Cancer Research Fund recently did a statement saying that 50% of cancers could statistically be avoided with healthy lifestyle, including diet. But of course, it's very hard to start teaching teenagers to eat healthily. But in terms of relapse, there is also evidence that if you change your diet after you've had your cancer, you can reduce your risk of relapse. This was a really nice study by Pierce, again published in JCO, which showed that diet more than 5 a day plus exercise, you had a lower risk of breast cancer relapse compared to less than 5 a day. This one was looking at whether you had lentils or pulses in your diet, and if you had lentils and pulses, you had a lower risk of breast cancer. And this one actually looked at whether you had soya intake after breast cancer, and if you had high soya intake, you had a lower risk of relapse. Oncologists still tell people you mustn't have soya after breast cancer, because they think it's estrogenic. But actually, the evidence is completely opposite, that soya reduces your relapse rate. What is dangerous if you have soya tablets, which then you're sort of over getting the estrogenic effect, and you can get a stimulation of the receptor. But soya in the diet will reduce your risk. So, of course, it would be convenient to put diet into a pill, and of course all these exhibitions downstairs are trying to do that. We know that if you have a poor diet, taking a supplement will compensate a poor diet, but it's possible, even if you have a normal diet, you could concentrate these polyphenols and increase your cancer effect from food. And we know that many people are interested in taking supplements and other complementary therapy. You know, the general population, about 30% will take it. This could be any cancer, not just prostate cancer, but between about 60 to 70% of people with cancer take some sort of complementary therapies and particularly nutritional supplements. So as an oncology community, we could ignore that, or we could try to guide people, and this is what happens. They all say, oh, it's all rubbish, don't do it. Or we could guide people to the things which work and the things which don't work, and try to get evidence for that, which is where I'm sure you feel is the right path, don't you? So just putting supplements into 3 categories, I'm sure it's much more complicated than this. This is just from my understanding. Of the nutritional supplements, there's ones which are drugs which are used for dietary purposes, but it's not their licensed indication. There's whole food supplements where you just get the sugar and the pulp out and just concentrate them, and you're basically just taking a whole food capsule. And there's extracted chemicals such as minerals and vitamins. There's a lot of interest for metformin at the moment, which is a treatment for diabetes. It reduces your blood sugar if you've got type 2 diabetes. The way it does that is it reduces insulin resistance. So insulin becomes more effective, because that's part of diabetes, is you become resistant to insulin. So it reduces that. But it also has some direct anti-cancer properties, either through this mechanism, protein kinase, but it reduces the insulin-like growth factor, which we know, if you increase insulin-like growth factor, it promotes cancer cells. So they sort of came across with this common treatment for diabetes might have a cancer effect. And there's lots of studies now, including this one from Memorial Sloan Kettering, to show that if you had men with prostate cancer and diabetes, if they were on metformin, they had a significant reduction in their prostate cancer relapsing and an improvement in mortality. So if they were on glycoside, which is the other one, they had no benefit. But if on metformin, they had a significant benefit. So I already tell people who are diabetic now to switch from glycoside to metformin, which is an unlicensed indication. That's why we're talking about it. So it's a dietary manipulation through a drug. But the really interesting thing, the NCI, National Institute of Health in California, there is 9 ongoing randomized trials of metformin in people with cancer to see if it has a cancer effect, including one from Toronto, which is in prostate cancer, where these people are non-diabetic. So we're using a diabetic drug to treat cancer. Or, of course, I'm more along the line as you get people to lose weight and exercise, which are actually the same thing. But we did a study of 400 people with prostate cancer in Cambridge, and only 4% of them exercised more than 3 hours a week, and most were overweight. So, you can see why a pill is attractive. Coming on to minerals and vitamins, which is the other category, there are some benefits. I mean, there was a recent study showing that if you had vitamin C after breast cancer, you reduced your relapse rate. There was another study from France called the CUVI Max study, which had a vitamin C, E, A, selenium, zinc, and they found it reduced the prostate cancer incidence. And now and again you get one showing it helps bowel cancer, so it doesn't. And certainly if you're deficient in any of these, it helps to take a supplement. The trouble is, we don't know if we're deficient or not, and if you take too many, like in these trials, which was a randomization of synthetic vitamin A and vitamin E, it actually increased the lung cancer risk. These were people with lung cancer. They had a vitamin, and they followed them up against placebo and had to stop the trial early because the lung cancer risk was higher in the vitamin A group. The same was seen in this other lung cancer trial, and the same was seen with vitamin E and selenium in the prostate cancer SELECT study. That actually selenium and vitamin E increased your prostate cancer rate, not decreased it. And the reason is probably that they were giving it to people who had normal selenium and more normal vitamin E, and they were giving not the gamma vitamin E, which you get in normal food, but a synthetic version of it. So you've got to be careful with these chemicals because they are extracted and they're put into a pill in quite high quantities, much higher than you get in food or whole food supplements. So the only way we could do it is what on my website. You can buy a micronutrient test. You can measure your levels, which is, again, only a snapshot at that time, mind you, and you can replace what you're deficient in. Well, these are very expensive tests, and most people can't afford them. We're trying to get funding for a trial to do this, but that would be the only way of knowing for sure. And in fact, the Memorial Sloan Kettering, which is a very good cancer hospital in New York, has actually got a statement now, and they embrace complementary therapies. In fact, they're probably the best resource for complementary therapies to do with oncology is the Memorial Sloan Kettering website. I mean, it's very comprehensive. They actually say, we do not recommend long-term mineral and vitamin supplements unless you're correcting a known deficiency. Not if you just had a bit of cold or you're short-term. So coming on to whole food supplements, now these are your saw palmetto, lycopene. Well, lycopene is a bit of a chemical, isn't it? Because it's the polyphenol within tomatoes, but I've sort of kept it in there. These sell billions of dollars worth in the United States and around the world, extrapolating that if tomatoes and healthy foods stop cancer, prostate cancer, taking more of it, would that reduce the risk of it progressing? Well, saw palmetto was randomized in a large US study, had no benefit for benign prostatic hypertrophy or cancer. The same applied for genistein and lycopene. So there's not many of these actually showed any benefit. Saying that, they tend to be small studies, underpowered, and they were sort of probably using the wrong things. So that comes back to this document where it clearly says we need more evidence. Now, none of the trials showed that they were doing any harm, mind you, unlike the vitamins and minerals. So I was fortunate enough to be on this committee. It's called Complementary Therapy and Lifestyle Clinical Trial Subcommittee, which is a subcommittee of this organization called the National Cancer Research Institute. This is a government body set up to try to find holes in medical knowledge and design trials to find the knowledge. And we had, at that stage, a complementary therapy subcommittee, which also included lifestyle. So they sort of think that exercise is a complementary therapy, but that's same as going to church was a complementary therapy, I discovered in that meeting, which is interesting. So anyway, we sat down, we said, look, we don't want to do any more trials on vitamins and minerals. We'd love to do an exercise trial, but we did design 3 and we never got any funding, which is a shame. That's ongoing. But we thought, well, look, there is a bit of, there seems to be a gap in knowledge for whole foods. So we sat down as a group over 18 months and we looked at the evidence for certain foods having anti-cancer effect. Now, of course, we had a league table of about 40 or 50 things. It could have been coriander, could have been cactus, any sort of chili, pepper, all these sort of polyphenol-rich foods came into the list. But the ones which sort of became sort of towards the top end were these 4. So green tea, curcumin, pomegranate, and broccoli. Look at the analogy of Manchester United. They've bought 300 million pounds worth of players, haven't they? And they haven't won a game. So what the manager's done is just said, I want 11 of the best football players in the world. But of course, that's not they don't work together. You need football players who can play as a team. And that's what we've done with this. We've said there may be other things, other types of tea or other types of curcumin. Green tea, for example, tends to reduce proliferation apoptosis, whereas curcumin tends to reduce the markers of migration and also stop stem cells growing into mature cells. Pomegranate tends to have loss of adhesion effects, and broccoli changes your genetic signature. If you eat a lot of broccoli, you can actually see 180 changes in your DNA where the genes which suppress cancer are promoted and vice versa for the promotion genes. Although there's a lot of overlap, they tend to work in different ways, and the hypothesis was we could have polyphenol-rich foods which have, in theory, from laboratory studies, they've all got some laboratory studies behind them, and some small phase 2 clinical studies, who could work together and have an anti-cancer effect. But we don't know that's true, but we thought we'd do the trial. So we formulated it. We had to find a company in the UK to make it, and had to be made, of course, with a standard which would be accepted by the NCRI. So it had to be, in fact, we had to get mass spectrometry of the ingredients to check they hadn't been contaminated, which is a really expensive biochemical test. We had to check for trace elements, and it had to be FDA registered. And we came up with that. We got some money from Prostate Action, so thank you very much for that. The NCRN, which is the government body, audited the study, so actually ran it. So this was a government study. It was non-commercial, so this wasn't a product in those days. We went out and got it made specifically for the study, and we had 2 nurses provided by them. So we ran it on a bit of a shoestring and got it started. We picked prostate cancer to start with, because even though these have probably, in theory, anti-cancer effect for all cancers, there's a lot of men with prostate cancer in the UK who don't need any other interventions because they've got slow-growing disease or they've relapsed post-radiotherapy and the PSA is going up slowly, where the evidence is you should hold back on hormones and wait till you see the whites of their eyes, the PSA start going up rapidly, and then you come in. So there's a large group you can experiment on, for want of a better word, where they're not on any other treatments. So that's good. We'd love to do the same with other tumours, but we started with prostate. There was a randomized trial. People didn't know what they were on, so they could have been on placebo or the POMI-T, and the doctors didn't know what their patients were on, and the statistician analysing the study didn't know what Group A and Group B was. The randomization process, this is just for just to show that the randomization process worked. There was a slightly older group in the placebo, but that would work in a favour of the placebo. We looked mainly at the marker of prostate cancer, PSA, but we had other endpoints as well. And this is what really excites us. This was the target set to us by the NCRN. What they say is, when you're doing a clinical study, even though they didn't give us any money, they effectively gave us nurses, so they see it as money. They said, if we don't meet that accrual target, we'll withdraw your nurses, or threaten to. The day we opened the study, we had phone calls from around Britain from patients saying, I want to be in your study. So if you're doing a drug study, you have to go around begging people to be in it, usually. And most of the time they say no when you've explained it. This shows a lifestyle study or a nutritional study. We were having to turn people away. We finished recruitment 11 months ahead of schedule, and even we got another 50 just to increase the statistical power, which we had to apply for. So this was a great example to medical research, and this is a study which people want. Now, this was really nice. The world's most prestigious conference is called ASCO, American Society of Clinical Oncologists. And there's 28,000 oncologists from around the world attend. And for each subject, like prostate cancer, breast, bowel, etc., they pick 10 talks from around the world to be presented. And we were very lucky to have this study presented. The other 8 talks were all from massive pharmas, and they were all billion-dollar project biological drugs. The 2 talks from the UK, one was on metformin, and the other one was on POMI-T. And, it's not only great for us, we were very privileged to have gone, it actually shows that even ASCO, even a mainstream oncology society, are now beginning to recognize that there may be treatments for cancer staring us in the face. And we need to put money into this, not drugs which are costing £97,000, which is the last breast cancer drug we just had approved. At 6 months, there was a 64% difference in PSA progression between the people who were on the food supplement and people who were on placebo. So, and this was, as I say, independently audited, independently statistical approved, and very significant. So this could not have happened by chance. Or it was a 1 in 8,000 probability it happened by chance. What it actually was showing that the PSA rate of rise slowed significantly. In some people, the PSA still continued to go up, but at a slower rate. And obviously in some it didn't work at all, like any product. And in some it actually dropped. So it gave people more time, either where they would never then need radiotherapy or hormones, because they're sort of already quite old, or it might give them 4, 5, or even 6 years before they then need that intervention and all the toxicity. This is a nice study showing that there was a 20% difference, even at 6 months, to people who'd chosen to have hormone therapies or stay on this lifestyle intervention. That actually means that's 20% not having radiotherapy, hormone therapies, and all the consequences of those treatments. So this is clinically relevant. This is just a side effect profile. There was a very few side effects. You could get a bit of a bloated stomach if you weren't used to those foods. And some people got a bit of diarrhea, but some people said they were constipated and they got better. So they're not without side effects, but quite minimum. So this is just to wake you up. This is Peter when he was younger. No, it's not just to wake you up. This is to remind me to say, because when we got this published, it was sent back from the publication 4 times because they said, oh, we don't believe you. I said, well, AstraZeneca, their study of Zoladex, which is a $1 billion a year product, got a license for a reduction in PSA. So we've got a reduction in PSA, but you don't believe us. So why do you believe AstraZeneca? So it was a bit strange, and it was run through the government, so it was all kosher. They wanted all the original data, so we sent them all the original data, so they looked at it through a time to and then say, oh, it only worked by reducing testosterone. Fortunately, we'd measured testosterone. There was no effect on testosterone in the men, so it wasn't a phytoestrogen supplement, so we were able to show that. And then they said, aha, well, you're just lying because it's just a blood test you've treated. I said, but we've also done MRI scans. And now, with diffusion-weighted MRI scans, you can actually see the tumour within the prostate gland. So fortunately, in our practice, we've switched over to doing annual MRI scans on men with prostate cancer. We can actually measure the tumour. So there was not a single patient whose PSA had gone down where the tumour had either stayed stable or gone down. There wasn't a single patient where the PSA had gone up where the tumour hadn't grown. So then they said, OK, you're satisfied. It got published. But it was hard work. And it got published this is a well-established prostate cancer journal. If you want the full paper, you can download it from that website, and they can print it out. The product then got commercialized by the manufacturers, which, of course, we're not manufacturers, so we were quite happy with that. We knew that patients would be interested in buying it, and we do support them, because hopefully when they do well, they can put money back to us, and we can do more research as a consequence. As long as they meet the same quality assurance which the trial had. Since the trial's finished, we've developed an app on an iPhone which helps describe PSA doubling time, which you may think is a bit odd, but it's actually a nice little tool. So you can say to people, look, you've started a lifestyle intervention here, and this graph is your PSA doubling time, the rate of rise of your PSA, and it's dropping. So actually, it's not working. So you do need to have an intervention. Even though your PSA is still quite low, it's got shorter, the rate of rise, so you need an intervention. Whereas other people, if it's gone up, you say, look, although it's gone up a little bit, it's going up at a much slower rate, we can reassure you, stay on lifestyle. So it's a nice little tool to help describe things. We're hoping to do more trials on different stages of prostate cancer, people who have already started hormones, to see if it would prolong the effectiveness of hormones, which we think it will, because anecdotally we're getting emails from around the world saying they think it is, but we need to prove it with a trial. But this is a really nice one. Jack Cusick was voted in the top 10 scientists in the world. He's head of the Institute of Preventative Medicine in St. Bart's, London, and he's done a number of studies, including one just started called the PROVENT study. Now, the PROVENT study is, there's someone called Ros Eales. Anyone heard of Ros Eales from the Royal Marsden? She runs a genetics unit. She's trying to find, for men with prostate cancer, the BRCA1 and BRCA2 genes, which Angelina Jolie had, so we can find men who have got an increased risk of prostate cancer. Of course, and she's got some genes, or certainly got men with a strong family history with a very high risk of getting prostate cancer. She doesn't know what to do with them. So she approached me and said, can I go and talk to Jack Cusick? And Jack Cusick said, perfect, what we'll do, we'll put all those men into a study, A national study is going to be in 60 hospitals around the UK, and he's chosen vitamin D, aspirin, and POMI-T as the 3 arms, and placebo. So it's really good for us to have that credibility and further evidence that it could help prevent prostate cancer in that case. We're also going to do some other studies on lung, bladder, ovary, again, funding provided. There's actually, may have some money from Singapore from last week looking at sperm count, funny enough, because one of the guys thinks that these sort of foods could increase sperm count, but we don't know, and obviously that's an easy study to do, so that's one we're actually quite excited about. But what we have got money for, and what we are starting, is a study on arthritis. Because as you know, I'm sure there's many nutritionists in the room, those foods I just described, they have effects on chondrocytes. They've been shown in a lab to prevent chondrocyte degeneration, and these foods probably work by stopping arthritis developing. The problem is the trials up to now have been with people riddled with arthritis. You give them, say, green tea extract, and there's no benefit. Well, it's too late then. What you need to do is come in early to prevent arthritis. And of course, we can't do a study and wait 20 years to see if it works, can we? But in breast cancer, we give tablets to people which induces arthritis in 45% within 3 months. So we have a perfect model. So we can give this supplement or placebo, start them on the breast cancer drug, and at 3 months to see who's developed arthritis and who hasn't. So it's a great model. And obviously, we might extrapolate that to if we all take them through our lives, we're less likely to have arthritis. So that's starting. So that's really exciting. Just want to end on a sort of this is non-evidence-based now, but this is what I'm lucky. I've got a busy clinic, and I can see people who are very keen to help themselves. And this is the type of things I'm seeing on a day-to-day basis. These are some case reports, so I'd just like to share with you. For example, 53-year-old man, heavy smoker, poor diet, no exercise, chronic obstructive airway disease. He was sent to us, and he was not fit for chemo, radiotherapy, or surgery. So he was basically sent to us to die. We said, look, we can't treat you with anything, but you could, just try and help yourself. So we got him to stop smoking. We sent him to the physiotherapist. So we're using non-cancer professionals to treat cancer patients who got him to walk. And when we said, do you eat any vegetables? His answer was, what's a vegetable? So he did eat chips. So that is a vegetable, there's vitamin C. But we managed to take some vegetables. It was quite a surprise. And within about 3 months, he gained weight because he was very thin. He started walking with a stick and even started power walking in the park in a walking group. This was his chest X-ray when he arrived. 19 months later, absolutely it actually shrunk a little bit and didn't change at all. So just by changing his lifestyle, this man's squamous cell carcinoma of the lung, which is 95% of killing you with 1 year, didn't change. He then had a heart attack, mind you, so we can't give him complete credit. So when he died, he had no progression of his cancer, which I think is a success, is it? No? I'm not sure. Case 2, 59-year-old woman, colon cancer resected in 2008. She relapsed with lung and liver mets 2 years later. We can often resect them, but we couldn't in her case. We said to her, this is not me not doing conventional medicine. This is a normal consultation. You said, look, you've got no symptoms. Your disease has come back. It's asymptomatic, so you've got no symptoms of it because it's small volume. We can give you chemotherapy now, which will shrink it, but you then get all the side effects of chemotherapy and you'll still have your cancer. Or you can just adopt a lifestyle and healthy living program, and we'll keep a close eye on you. And if your cancer is progressing, we'll then give you chemotherapy. So there's nothing wrong with that. That's mainstream oncology. Nobody's going to shoot me down for being a quack or anything. Still got the chemotherapy up my sleeve. She went into an exercise referral program. She'd never been to a gym in her life. She exercised 3 times a week. She stopped all sugar and processed meat to reduce her carcinogenic exposure. She then bought my book and was thumbing through all the pages, how to avoid carcinogens, and she took POMI-T. This was her lung met. Well, she had lots of disease, but this, for example, is a metastasis in the lung. That's a CT. Over 2 years later, the lung met is smaller. And the CEA, which is a marker for her cancer, reduced. Last time I saw it, it was beginning to rise. So she's heading for chemotherapy. She's had 2 years of good quality of life with no chemo, and then she'll have a chemo. So she'll still get the same benefit of chemo, but she's added 2 years on top of it. Case 3, 60-year-old man, colon cancer. He had chemo at the beginning to try and prevent relapse. So again, mainstream treatment. He did relapse. He had abdominal nodes, which were picked up by the surgeon, asymptomatic. He'd had 2 CTs. You want to be careful when a lot of these case reports, people report cancer, but it's not actually cancer. But actually, in this case, we had the marker of cancer, and we'd had 2 CT scans showing it was growing. So it definitely was cancer. He went overboard. He joined the gym. He then did extra walks. He stopped all sugar, processed meat, reduced carcinogens, increased generally his polyphenol intake. He was having broccoli soup, other things like that. And he took Pomit, and he did an online nutritional test. He was found to be vitamin D deficient, so he corrected his vitamin D, and he was omega-3 deficient, and he corrected that. So he really, did a major change. And this is his abdominal node here, and this is it 2 years later. He still comes back every 3 months. You examine him, you do the markers. The tumor markers had reduced, and he's very happy, enjoying life. And again, chemotherapies, he's going to get chemotherapy eventually. What I'm coming from, I'm not promoting, waving a crystal around Stonehenge and not having chemo when you need it or not having surgery. I'm talking about practical lifestyle and complementary therapies which are cost-effective and really helping people's lives. And that's what I'm trying to promote to my colleagues. You're already converted. If you want to anytime we see a paper about lifestyle or complementary therapies related to oncology, we always send out a tweet or Twitter, and we do a monthly newsletter which you can sign on through there. So we just summarize, like the vitamin C study came out last week and the soil came out. So that's the type of thing we'll be on it. So thank you for listening. And if you want the evidence for that, it is there. And any questions? Sometimes the manufacturers, they constantly ask me questions like that. We sat down as a committee and we sort of worked out the dose based on what other people had used in their supplements and how many side effects people got. And within the study, you did see that some people who took, say, 3 a day would come back and say they got a bit of bloating and diarrhea. But it depends on what you're used to. Especially if you take it with food. Some people who've never had any turmeric in their life might find it a bit uncomfortable. But the doses, if you look at the turmeric studies, and there's one going on in Leicester at the moment, and a broccoli study going on in Norfolk, they're using like 5 times the doses. So, it's whatever you can take. You can't really overdose on these because they're whole food. But, I suspect if you take more than 3 or 4 a day, you'd probably get a bit bloated.
Do you think Pomit can help other kind of tumors? Because you focus mainly in the prostate. And do you have any idea?
Well, yes, we did the prostate trial because that was the first one we started, and we are hoping to get funding for other studies. But it's very hard to look at other cancers because they're all on hormones or chemo. It would be great to have 200 people with bowel cancer who've relapsed with asymptomatic disease, and you could do those case reports and do a randomized trial. But even then, they will do a number of different lifestyle things. Was it the Pomit? Was it the fact they were exercising? Avoiding further carcinogens. So it's very hard to prove that. For ovary cancer, we have got a model, because people who relapse with ovary cancers do have a rising CA125, which is a marker, and often we don't recommend chemo. In fact, George Fellows at Cambridge, after I presented this in Cambridge, said this is an exact model for ovary, because we don't want to come in with chemo, because in his opinion, you give chemo, it shrinks it, you stop chemo, and the disease is like poking a wasp's nest with a stick. It then goes bang. So you should do something more slow. And he said this would be perfect. So ovary would be one model, but it is hard to get the quantity of patients required for statistical approval. Saying that, when he developed it, the lab data was done on prostate, bowel, lung, all sorts of cancer. So we know there's laboratory evidence, but can you say there's clinical evidence? Well, you can't really if you're going to be pure about it, but the probability is it works. It's not working through an androgen route. It works just by an anti-cancer route. So yes, it probably does, but we need to prove it.
Would you recommend it for someone who doesn't have cancer but has try chemotherapy?
That's a good point. one of the doctors in Singapore said exactly that. The problem with urologists, they do a biopsy, it's negative, the man's got a high PSA, we know they have an increased risk of cancer. Now, they'd be eligible for the PROVENT study, and that's exactly what it's trying to prove. Could you prevent, well, we know that polyphenol-rich diets do prevent cancer, so the theory is, if you increase the polyphenols, you could have a better effect. But you can't say that for sure until you've done the study, but that would be something. I mean, I take it once a day because I know what's in it, and it sort of, helps my knee, which I had a bit of arthritis, but that could be a placebo effect as well. But yes, I mean, it may well have a role in that, and it'd be great, wouldn't it, if you could find something which you could give to everyone and reduce the risk of cancer by 30%. But that would be another big trial.
So the study program is for people having a cancer?
Well, there's a mix. It'll be people with, some of these would have had a biopsy and found to have a tiny, like one fleck of cancer, low grade, certainly don't need treatment. And it'll be others who've got a high PSA and some markers of inflammation where we know they're very likely to get prostate cancer within a couple of years. So it's going to be a mixed group.
When you mentioned originally that the POMI tea sort of selected the green tea, the curcumin, the pomegranate and the broccoli, those obviously were 4 elements. And there were other ones up there that sort of had been up there but were discarded. Yes. I mean, that sort of magic 4, as it were, was that actually sort of a conscious decision not to have too many items in it? Or were those 4 particularly more advantageous than the others in a mix? Sorry, or did you not?
Well, there were other, grapeseed extract was one which was a near miss.
Yes.
And there was a study showing grapeseed extract. You could have used coriander, anything, anything green, herbs. You could have put pepper in it because it enhances the absorption of turmeric. But, of course, we're giving, certainly in the prostate population, most of these people are not very adventurous with their diets. Of course, you have the size of a pill is an issue. If you have, the more you have in, the more dilute it is. So we had to have a reasonable concentration. So it was sort of trial and error, really, to be perfectly honest. We can't say it's more scientific than that. We looked at what other people are using. So we need to be in the same ballpark dose, if you call it a dose, or concentration. So, yeah, but they could have been 10 other things which would have made the short list. Yeah, it was just pragmatic. We had, at the end of the day, do it. Okay, so a couple more questions. I noticed.
I just wonder if you have any information on how these chemicals are actually working at a cellular level.
Yes, we've got lots of cellular data. There's no shortage of cellular data. In fact, if you go to NCI, with National Cancer Institute, there's hundreds of trials on cell lines and animal studies. And yeah, they work exactly like how we want drugs to work. They block enzymes which promote proliferation. They block enzymes which promote de-differentiation, so they stop the cell getting more aggressive. They stop markers of you can measure markers of loss of adhesion and metastasis, for example. They seem to block. They cause cells to stay sticking where they ought to. They don't promote markers of proliferation. They tell cells to die when they ought to, apoptosis. So all the hallmarks of cancer, all those 4 and others, seem to have those effects. And people argue, because in the cell line, the concentrations aren't the same as when you eat. That's why possibly you do need a supplement, because you would never be able to eat that much. Well, that's debatable. Whereas in the cell, you have very high concentration. But also, there's the nice thing about there was the turmeric study was giving it to normal cells. And they weren't having those effects on normal cells, but they were on cancer. So there's a lot of data on that. So, yeah.
Thank you.